Welcome to The Explainer. Today, we're going to dig into one of the trickiest things we do in psychiatry, trying to identify bipolar disorder before it really takes hold. We'll walk through the evidence-based markers that can help you spot that risk early on, and maybe, just maybe, completely change a patient's life. So here's how we're going to break it down. We're going to follow the whole developmental story of bipolar disorder. We'll start with those foundational risks, the ones in our DNA. Then we'll see how things like trauma and substance use can be the triggers that set things off. And finally, we'll get into the really subtle stuff, decoding the prodrome, and ask the most important question of all. What can we actually do about it? First up, why does this all matter so much? Why the big push for early detection? Well, it's because bipolar disorder is, for many, a neuroprogressive illness. That means with every single mood episode, the brain can actually change. This makes the next episode more likely to happen and even harder to treat. So a delay in diagnosis isn't just lost time. It can put your patient on a much tougher path. And the stakes? Well, they are literally life and death. A huge meta-analysis found that over a third of people with bipolar disorder will attempt suicide in their lifetime. This is not just a statistic on a slide. It's a shocking reminder of our responsibility to see these signs before it's too late. Okay, so where does this all begin? The story actually starts way before the first mood swing. It starts with the very foundation, our genes and the environment inside the womb. Genetically speaking, bipolar disorder is an absolute heavyweight. With heritability estimated somewhere between 60 and 85%, it is one of the most genetically loaded conditions we see in all of psychiatry. What does that mean for you? It means that a detailed family history isn't just a nice-to-have, it is your single most powerful predictive tool. But remember, genes only load the gun. It's often the environment that pulls the trigger. And check out this data from the Shintani meta-analysis. It's just stunning. Things like birth complications, yeah, they bump the risk up a little. But look at maternal stress during pregnancy. An odds ratio of 12. That is a massive signal. It strongly suggested a major stressor while in utero can have a huge effect on the developing brain, probably messing with things like the HPA axis and setting the stage for mood problems years down the road. So after birth, that genetic and prenatal vulnerability starts to interact with the outside world. And the next major risk factor we have to talk about is childhood trauma. This doesn't just increase the chances of getting the disorder, it actually helps sculpt what the illness is going to look like. The numbers here, they make the connection just impossible to ignore. About a quarter of people in the general population report some kind of early trauma, but in our patients with bipolar disorder, that number doubles. We're talking over 50%. This tells you that for a lot of people, trauma isn't just something that happened to them. It's deeply woven into the biology of their illness. And this is exactly why you have to get specific when you take a trauma history. We are not just checking a box here. Knowing that a history of sexual abuse more than doubles the risk for rapid cycling, or that emotional abuse makes suicide attempts significantly more likely, that information allows you to anticipate how severe the illness might be and to really tailor your management plan right from the get-go. And really, the data points to a very clear dose-response relationship. As Jansen and colleagues put it, there's a dose-related effect. The more traumatic events someone experiences, the worse their prognosis tends to be. We're talking earlier onset, more hospital stays, just a more severe illness overall. When it comes to trauma, the quantity really matters. All right, the next critical window of risk is adolescence. This is when substance use often comes into the picture, and it can act as a really potent trigger, unmasking a vulnerability for bipolar disorder that was just sitting there under the surface. Now, the order of events here is a huge diagnostic clue for you. Study after study shows the same pattern. For a lot of patients, the substance use disorder starts before the first full manic episode. This is so important. It tells us that substance use isn't just a complication that comes later, it might be the very thing that kicks the whole illness into gear. And the data on cannabis, wow, it is particularly stark. The Nemesis study found that just weekly use, we're not even talking daily use, just 1 to 4 times a week, was tied to a nearly 9-fold increase in the odds of developing bipolar disorder. That is an enormous risk signal from what many people consider pretty moderate use. We have to be asking about this. And then there's cocaine. When you're wrestling with that classic differential, unipolar versus bipolar depression, this is a massive red flag. If you have a patient who comes in looking like they have major depression, but they have a history of cocaine use, your suspicion for an underlying bipolar illness needs to go through the roof. The data shows it triples their risk of eventually switching over. So you've got the genes, the environment, the substance use, and it all kind of funnels down into what we call the prodrome. This is the final pathway, this critical window where you see subtle symptoms. It can last for years before the first full episode, and frankly, it's our best shot to get in there and intervene. In the prodrome, our job is really to separate the signal from the noise. The noise is all the nonspecific stuff, the heterotypic symptoms. Think anxiety, sleep problems. They're common in tons of conditions. The real signal is the specific homotypic symptoms, bursts of irritability, brief periods that look like hypomania but don't quite meet criteria, and just significant mood swings. These are the true warning signs of bipolar disorder. And this number right here, this represents our single biggest diagnostic challenge. Almost 1 in 4 patients who we first diagnosed with depression will eventually go on to have a manic or hypomanic episode. Our job is to figure out who's in that 22.5%. Because if we get it wrong, it can mean years of treatment that's not just ineffective, but could actually make them worse. So how do you spot them? How do you pick them out? Well, the evidence gives us a very clear 3-point checklist. When you're assessing a young person with their first depressive episode, you have to screen for these 3 things. Are there any psychotic symptoms? That's almost a 5 times increased risk of conversion. Is there a family history of bipolar? That's almost a 3 times risk. Did the depression start at a really early age? These are the evidence-based signposts that should make you stop and think before just writing a prescription for an SSRI. Okay, so we've done the detective work, we've identified a patient who is at high risk. Now what? What does the evidence actually say about what we should do in this really fragile pre-illness phase? The evidence here really points to one main principle: safety first. Things like psychoeducation, CBT, and especially family-focused therapy are safe, and they're really promising for building resilience and coping skills. But starting a mood stabilizer, that's highly controversial. The evidence that it works in this phase is pretty thin, and you run the risk of exposing a patient who might not ever even develop the full illness to some pretty significant long-term side effects. The risk-benefit ratio is just questionable. So what's the big takeaway here? The evidence we've just walked through shows that a patient's first depressive episode is never just that single moment in time. It's really just one point on a much longer developmental path. Taking a thorough history isn't just about good paperwork. It's an act of prediction, and it's an act of prevention. It's how we see the whole story and how we can really change the ending for our patients. So I'll leave you with this question to take with you to your next clinic. How will this evidence change your approach?